Welcome back, I'm Mr. Luis, and today we'll be exploring anxiety disorders and fear-related disorders. These conditions can have a profound impact on a person's life, causing distress and impairing their ability to function in everyday situations. In this video, we'll focus on three key anxiety disorders: Generalized Anxiety Disorder, GAD, Agoraphobia, and Specific Phobia. Along the way, we'll discuss diagnostic tools like the GAD-7 and Blood Injection Phobia Inventory, BIPI, that help assess the severity of these disorders. We'll also explore influential studies that enhance our understanding of treatments for these conditions. So let's get started. Anxiety and fear-related disorders are characterized by excessive fear or anxiety that disrupts daily life. To qualify as a disorder, the symptoms must be severe enough to cause significant distress or interfere with at least one important area of a person's life, whether that's their relationships, work, or social activities. While fear is a natural response to immediate threats, anxiety tends to be a reaction to future threats, things that are perceived to be dangerous but may not exist yet. The key difference between these two emotions is critical to understanding how anxiety disorders develop. Each anxiety disorder typically has a specific trigger that sparks the emotional response. For example, Generalized Anxiety Disorder, GAD, involves persistent worry or anxiety about various life events. This anxiety lasts for at least 6 months and is often accompanied by physical symptoms like muscle tension, restlessness, and difficulty sleeping. Individuals with GAD struggle to control their worry, and this affects their ability to function in daily activities and relationships. Next, let's discuss agoraphobia, which is the fear of being in situations where escape may be difficult or where help may not be available if a panic attack occurs. Common triggers can include public transportation, crowded places, or even being outside the home alone. This fear leads to avoidance behaviors, where the person limits their activities and social interactions. Over time, this avoidance can severely restrict their lifestyle. Lastly, we'll look at specific phobia, which is an irrational fear of a particular object or situation. Some common examples include fear of animals, heights, or certain situations such as flying or receiving medical treatment. A specific form of phobia is blood injection injury, BII phobia, where individuals experience extreme fear when confronted with blood, injections, or medical procedures. This fear can sometimes be so intense that it causes fainting or an inability to function in situations involving these stimuli. To diagnose these disorders, clinicians often rely on tools like the Generalized Anxiety Disorder 7, GAD-7 questionnaire, and the Blood Injection Phobia Inventory, BIPI. The GAD-7 is a self-report tool that helps assess the severity of generalized anxiety symptoms. It asks individuals about experiences like irritability, restlessness, and difficulty concentrating, with responses ranging from 0, not at all, to 3, nearly every day. The total score, which can range from 0 to 21, helps determine whether a person's anxiety is mild, moderate, or severe. Similarly, the BIPI measures how severely a person with BII phobia reacts to blood, injections, or medical procedures. The inventory evaluates the person's cognitive, emotional, and behavioral responses to these triggers. It helps clinicians assess the severity of the phobia and tailor the treatment plan accordingly. An interesting study by Moss et al., 2010, explored whether the BIPI could differentiate between individuals diagnosed with BII phobia and those without it. The researchers found that the BIPI had high concurrent validity, meaning it correlated well with other established anxiety measures, such as the fear questionnaire. This finding supported the BIPI as an effective diagnostic tool for BII phobia and demonstrated its ability to track improvements in symptoms over time. Chapman and DeLapp's 2014 study aimed to investigate whether a combination of cognitive behavioral therapy, CBT, and applied muscle tension, AMT, could help a 42-year-old man, referred to as T, reduce his fear response and better tolerate medical procedures involving blood or injections. Individuals with BII phobia often experience severe anxiety at the sight of blood or medical procedures involving needles. This anxiety can be so intense that it causes them to faint due to a sudden drop in blood pressure. Although CBT has been shown to be effective for treating specific phobias, BII phobia presents a unique challenge due to its physical symptoms. Chapman and DeLapp aim to combine CBT with AMT to address both the psychological and physiological components of BII phobia. The study is grounded in cognitive behavioral theory, CBT, which focuses on changing negative thought patterns that contribute to phobias. For BII phobia, individuals often have irrational thoughts about medical procedures, leading to avoidance behaviors. AMT, which involves deliberately tensing muscles to raise blood pressure, helps counteract the fainting response caused by anxiety. The study used a case study design focusing on a single participant, T. Over 9 CBT sessions, T was gradually exposed to medical procedures involving blood or needles. At the same time, T learned to use applied muscle tension techniques to prevent fainting. The success of the treatment was evaluated using self-report measures like the Beck Anxiety Inventory, BAI, and Beck Depression Inventory, BDI, both before and after treatment. The results showed that the combination of CBT and AMT was highly effective. Before treatment, T experienced significant anxiety and fainting episodes during medical procedures. After the treatment, he was able to undergo medical procedures including blood tests without fainting or extreme distress. The self-report measures indicated a significant reduction in anxiety and a marked improvement in his quality of life. Chapman and DeLapp concluded that CBT combined with AMT successfully reduced T's anxiety levels and physical symptoms of fainting. The treatment allowed T to engage in medical appointments and procedures without fear or avoidance. The results indicated that the approach was effective in treating both the psychological and physiological symptoms of BII phobia. The study concluded that CBT combined with AMT is an effective treatment for BII phobia, particularly for individuals who experience fainting during medical procedures. By addressing both the mental and physical aspects of the phobia, the treatment provided a comprehensive solution. The study also suggested that this combined approach could be useful in treating other phobias involving physical symptoms, such as fainting, and could be adapted for broader therapeutic use. Several theories help explain the development of phobias, including both biological and psychodynamic perspectives. From a biological standpoint, researchers suggest that certain individuals may be genetically predisposed to develop specific phobias. OST, 1992, found that people with BII phobia often have family members with similar conditions, suggesting a genetic link. This predisposition may have evolved as a protective mechanism against dangers, such as the sight of blood, which historically signaled injury or death. This evolutionary explanation highlights the survival value of avoiding potentially dangerous situations. On the other hand, Freud's psychodynamic theory offers an alternative explanation. According to Freud, phobias may arise from unresolved unconscious conflicts. In his famous Little Hans case study, Freud proposed that little Hans's fear of horses was not about the horses themselves, but a displaced fear of his father, rooted in the Oedipus complex. Freud suggested that the child unconsciously feared his father due to his rivalry for his mother's affection, and this fear manifested as a phobia of horses. Although Freud's theory offers insights into the unconscious origins of phobias, it is based on a single case study and cannot be generalized to all individuals with phobias. The cognitive behavioral model, which emphasizes learned behaviors and irrational thoughts, is often more applicable for treating phobias. It explains how phobias develop through classical conditioning and reinforced avoidance behaviors. One widely used treatment for phobias is systematic desensitization, a form of behavioral therapy. It involves gradually exposing a person to the feared object or situation, while simultaneously teaching them relaxation techniques. This process, based on reciprocal inhibition, helps individuals learn that relaxation and fear cannot coexist. Over time, this reduces the emotional intensity attached to the phobic stimulus. Virtual reality therapy, VRT, is another promising treatment. It allows individuals to confront their fears in a controlled virtual environment, making exposure therapy more accessible and immersive. VRT is particularly effective for phobias like fear of flying or heights, where real-world exposure might be difficult. While psychological treatments like CBT and systematic desensitization are effective for many, medications may also play a role, particularly in severe cases. Selective serotonin reuptake inhibitors, SSRIs, are often prescribed to manage anxiety symptoms. However, medication is generally used alongside therapy, as long-term solutions are more effectively found in behavioral and cognitive interventions. As we've discussed, phobia treatments like CBT and systematic desensitization are effective, but there are important issues and debates in the field. One debate centers around the nature versus nurture question. Are phobias inherited, or are they learned through experience? The biological perspective suggests that individuals may be genetically predisposed to phobias, but the behaviorist perspective argues that phobias are learned behaviors that can be unlearned. Additionally, the concept of determinism is significant. If phobias arise due to genetic predisposition or early life experiences, can individuals truly overcome them, or are they destined to be controlled by these factors? The free will perspective suggests that therapy can empower individuals to change their responses and behaviors, regardless of their background. Lastly, we must consider the cultural context. Phobias and their treatments may be expressed differently in various cultures. For example, CBT has been shown to be effective in Western settings, but the methods and beliefs around mental health may differ in non-Western cultures. This raises questions about the cultural relevance of certain treatments and the potential need for adaptation. To wrap up, anxiety disorders like Generalized Anxiety Disorder, Agoraphobia, and specific phobias such as BIPI phobia can significantly disrupt a person's life, but effective treatments like cognitive behavioral therapy, CBT, and applied muscle tension, AMT, offer hope for those affected. These therapeutic approaches address both the psychological and physical components of anxiety, providing individuals with the tools to manage their symptoms and improve their lives. Thank you for joining me today. I hope you found this video helpful. For further details on the diagnosis and treatment of anxiety disorders, be sure to refer to the ICD-11 and DSM-5 TR. Until next time, goodbye.